Thank you, friends. On behalf of Clinical Epidemiology Unit, there's an echo, no? On behalf of Clinical Epidemiology Unit at AIIMS New Delhi, I welcome all of you for this guest lecture. I'm sure perhaps the person who needs the least introduction in this room is Dr. K.S. Reddy. I might need introduction, but definitely Dr. Reddy will not need any, any introduction. But still, we will introduce him formally subsequently. So when I took over as faculty in charge of clinical epidemiology and then tried to revive it, so one of the things that I thought was we'll start a guest lecture, and then I started discussing possible names for it within CU, within department, and one name kept coming up, Dr. K.S. Reddy. Why don't you invite Dr. K.S. Reddy? So it was almost you're the most popular choice for an inaugural guest lecture for clinical epidemiology. The topic of evolution of clinical epidemiology was suggested by me, then he built on it. Also when Dr. Srinath, he is busy with some VIP, this thing, but he will shortly join us. I talked to him briefed him about the School of Public Health and all. His first reaction was, why don't you involve Dr. K.S. Reddy in your School of Public Health? So there were multiple reasons why Dr. Reddy is here from my side. But before we go and talk about a brief introduction to Clinical Epidemiology Unit, first, many of you who may not know, AIIMS has a long history with Clinical Epidemiology Unit. Not many in this room might be aware. And some of Dr. Pandav, and there are many people who are Dr. Jennifer Lobo, obviously Dr. Reddy also were associated with CU for a long time. So I come from a very illustrious heritage of people in charge of clinical epidemiology. I'm trying to, it was a bit of a dormant for last couple of years. Now I'm trying to see whether we can do more with clinical epidemiology unit. I also met the Dean, Dr. Verma, and discussed how we can strengthen clinical epidemiology unit, and I hope to follow it up soon with that. So the idea for clinical epidemiology unit is a multidisciplinary unit from all clinical departments. We can join together, and I am adding, with the concerns of other CU members, that we should be focused more on, because it's a clinical epidemiology, the core should be on patient care, improving patient care at AIIMS. So with that thought, we thought we'll have a vision of building epidemiological capacity of AIIMS staff to generate evidence for strengthening patient care, and to serve as an interdepartmental faculty for capacity building in epidemiology, conduct research, and be a sort of an independent advisor, internal advice to AIIMS administration. So there are three pillars of work that we propose to take up. Building capacity in epidemiology through fellowships, courses, workshops, guest lectures is one of them. Assessing and improving quality of care, we might start focusing with medical certification of cause of death. Some work we have done, we will share with it subsequently. And also maybe look at employees' health and wellness, because that's an area that concerns all of us. And then do some secondary analysis and maybe do some primary research. Especially if everybody agrees, we can move and set up an employee cohort to look at even patient employees' wellness. Not necessarily focus, need not necessarily be a disease, but it could also be absenteeism and wellness and those kind of issues. As a part of secondary data analysis, one of the things that we have recently done is to set up a census data workstation, which was an MOU with Office of Registrar General of India and AIIMS, where you can have access to census data. Obviously now till 2021 or whenever the next census happens, we have data for the previous census. Microdata is available based on request, which will be vetted by an AIIMS ORGI committee, which has been set up. And then we can do analysis of census data. And we hope that in future, when I took over as CU, I was not sure where does CU stand legally or administratively within the AIIMS infrastructure. Is it an entity which has a sanction, or is it, because it started off as a more of an informal thing and then got integrated. So I'm trying to work with the Dean, the Dr. Verma, to see how we can make it inherent part of this, so that we institutionalize its role, whether it's in teaching or research. And we are fortunate to have some regular budget allocation, and see how best we can all strengthen the work of CEU. In the absence of Dr. Srinath, I would request Dr. Verma to felicitate Dr. K.S. Reddy. It's a small memento. I request Dr. Verma to introduce give his inaugural remarks and introduce the guest speaker.
Thank you, Dr. Anand Krishnan. Good evening, ladies and gentlemen. Very distinguished Professor K.S. Reddy. I see Dr. Pandab, distinguished members of the faculty, the scientists, colleagues, students, ladies and gentlemen. It's my honor and privilege to introduce Dr. Reddy. Not only this room audience, Dr. Reddy doesn't need any person who is connected with the healthcare in this country. And I don't know where to start from and where it should end. I have been given one page of his brief CV, but a book can be written on him just to describe his personality. I have known him for as many years as I have been associated with this institution, which is plus 40 years. He has been our teacher in cardiology when we were students. And after that, I have seen him in different roles and in different positions doing immense work. He is not just a celebrated cardiologist, but his work in the public health area, the epidemiology, which is even greater than what he has contributed. It doesn't mean that he has contributed less to the cardiology. He's a trained cardiologist and epidemiologist and the founder president of Public Health Foundation of India. And after that, he has established several public health institutions across the country for the advanced multidisciplinary research. And he is presently serving as the honorary distinguished professor at Public Health Foundation of India. He superannuated from the institute as professor and head of the cardiology department, but after that he got so engaged into various other activities related to public health, and we will very often see his columns appearing in the newspaper on different aspects of the health related to public health, the general health, advice to the people, the government. He was the first Bernard Lawn visiting professor to global cardiovascular health at Harvard, and presently as he is an adjunct professor at the Harvard University, and then to several other universities in the United States and in Australia. He is the first Indian to be elected as international member of US National Academy of Medicine. He was the president of World Health Foundation and also the co-chair of Health Thematic Group of UN Sustainable Development Solution Network. He is the member of a global panel of agriculture and food systems for nutrition. He served on several expert panels in WHO and in several other Indian and international agencies. I can go on and on. He is advisor to several organizations. He has been to Government of India and then to several state governments. He is still working and holding the cabinet rank by virtue of his position in those organizations and helping the governments. He has been not just the prolific writer, he has been a very eminent researcher who has published around 600 articles in different peer-reviewed international and national journals. He's written two books, Make Health in India, Reaching a Billion Plus, and Pulse to Planet, Long Lifeline on Human Health. And he received several honors, which was confirmed by the WHO, and of course, then the Government of India honored him with the Padma Bhushan, And apart from that, he has got several other prestigious awards. But I think the most important is that he is recognized as a very modest, soft-spoken, gentle human. He is willing to help anytime anybody who is approaches him, and he gives the advice the most appropriate and suitable to that person. I had little interaction. I don't know how much he knows me, but I know him so much that I can say with confidence that yes, he is one of the best people that you can have around in every sense. On behalf of the institute, though the institute belongs to him, I officially and formally welcome Dr. Reddy to deliver this first lecture of the Clinical Epidemiology Unit, which is he is going to talk about evolution of clinical epidemiology, anecdotes to evidence. I leave now the dais, the platform to Dr. Reddy for his lecture. Thank you very much.
Good evening. It's indeed an honor to be here, and definitely heartwarming to be back in an institution which has crafted my knowledge and created my career, whether in cardiology or in public health. And indeed, the Clinical Epidemiology Unit was the bridge between the two. So in 1987, when then director Professor Srinath Bhargava selected me as the first person to be sent out of 8 members ultimately who went for training in clinical epidemiology in different universities in the world. I went to McMaster University, and then others went to either McMaster University or University of Pennsylvania or University of North Carolina or the University of Newcastle in Australia. And that's how the Clinical Epidemiology Unit was first formed. And being in cardiology, but at the same time being introduced to epidemiology in terms of its precepts and practice was definitely helpful, not only in making me a better cardiologist, but certainly giving me a much broader vision of public health. So I owe a great deal to All India Institute of Medical Sciences and also to the Clinical Epidemiology Unit of the All India Institute of Medical Sciences, which I'm glad to see revived today. I'm grateful for the very kind introduction of the Dean, though I was a little worried about what would happen after the lecture ends. I was reminded of an anecdote where an absolutely terrible man who was always misbehaving with his neighbors, cruel to his children, and terrible to his wife died. And at the memorial service, when everybody from the preacher to all the others went through the motions of paying him great tribute, of saying what a kind person he was, what a gentleman he was, what a loving father he was, what a caring husband he was, a lady sitting in the front bench got up with her 2 children and said, "Let's go, we must be in the wrong church." That was his wife and children. I hope at the end of the lecture you do not feel you have been in the wrong church. So, Anand asked me to speak about the evolution of clinical epidemiology. Clearly, clinical epidemiology has a very vast terrain. I will not move into all of that. The slides are not moving, or shall I use this?
PDF. It's a PDF, so no.
I can move this? No.
Yeah.
No, I'm moving that. No, not moving. I should tap.
Yes.
Okay, fine. Let's go back. Okay. No, it's not. Yeah, good. Thank you. So basically, epidemiology and clinical epidemiology are integral to the purpose and process of health research. The purpose of health research of any kind is to provide evidence-informed, context-relevant, resource-optimizing, and culturally adaptive, as well as equity-promoting recommendations for policy and practice. Now, for this, whenever we undertake any enterprise called research, the idea is to frame a research question which we are interested in, then collect a number of observations related to that, and draw an inference which can then be applied. However, in that process of trying to attempt to find the truth that we are seeking, we have to contend with a number of influences which distort the truth, which interfere with our effort. And that is chance or random error. Chance has been called the eternal alternate hypothesis. So you have to always deal with that during research, because things could happen entirely by chance alone. The second is bias, which is systematic error, which can come in at any time in the design or in the conduct or even in the statistical analysis, and can then distort the whole process. Then you have variance that is built in, which you have to adjust for. And then confounding, which is a special form of bias, but where it is related both to the exposure as well as the outcome, and can interfere with the actual identification of what the relationship is. So given the fact that we have to deal with so many of these, we do require an understanding of that methodology which enables us to conduct research with as minimal interference from these as possible while we are seeking the truth. And then we have to deal with issues like internal validity. That is this particular study by itself, within the framework of its design, adequately conducted in order to provide the answer that we are seeking? Can we rely upon the answer? Then there is the external validity. Is the answer that we have derived from this study, is it applicable to other populations or others who are not part of this study, or who are not necessarily meeting the same description as the participants in this study? Then replicability. We know that by chance alone, we could actually get a positive result. So unless it also is replicated by other studies of a similar nature, then we cannot draw confidence that we have actually found the right answer. So all of these will have to be contended with, and that's why the science of epidemiology becomes absolutely important. And of course, now we are contending also with fraud in research. Even to find out what is a fraudulent publication, it is important to know what the tenets of the right methodology are, so that we can detect fraud, expose fraud, or at least not be misled by fraud. So what is clinical epidemiology then? Basically, it has been defined by Jean Paul, who in the presidential address to the American Society of Clinical Medicine in 1938, wanted the clinicians to understand that it is a marriage between quantitative concepts used by epidemiologists to study disease in populations, because epidemiology is generally looking at populations as the unit of study. But the same methods can be used by clinicians when they are studying patients. And he said, to study disease in populations and decision making in the individual case, which is the daily fare of clinical medicine. How do we transport those techniques and that methodology and that way of inquiry into clinical medicine so that we can bring in more scientific rigor into clinical medicine? So that was his attempt in 1938. And then subsequently, of course, a number of other people have adopted it, like David Sackett, who is considered the father of clinical epidemiology in North America. He called it the basic science of clinical medicine. But why do we need clinical epidemiology? Clearly, the mandate is to improve quality of clinical research and to base on scientifically sound research methodology, incorporating sound epidemiological principles and appropriate use of statistics, and to guide clinical practice through evidence-based medicine. Basically, decision-making, particularly by clinicians, should not be only eminence-based or emotion-based, but should be evidence-based. So that is the principle here. Is there a conflict with big E epidemiology? Now this brings in a question, how is it different from rest of epidemiology? Is there a divide? Unfortunately, David Sackett, who brought clinical epidemiology onto the big stage, had scant respect for observational studies. He believed that clinical trials were the only way to really look at things, and he felt that most other ways of looking at any research question would be inadequate, incomplete, maybe a starting point, but certainly not the finishing point of the inquiry. And therefore, he called it the big E epidemiology in a sarcastic manner. And that actually created a divide between observational epidemiology of people doing studies in populations and clinical epidemiologists doing studies in hospital or healthcare settings. But over a period of time, wisdom dawned and people recognized that there is really no divide. And doing studies in populations and doing studies in clinical settings, both must use the same sound research principles, though the applications are different, and there is a seamless continuum between the two. And then, apart from epidemiology and statistics, health economics and social sciences were also brought in, because you need to understand the implications of what we are really posing as a research question, not only in terms of the physical effects, but also in terms of the social determinants and the economic determinants of health. So all of these have now come together in the broader matrix of epidemiology and clinical epidemiology. And that's why multidisciplinarity became very important. And even when the initial first CEU was set up in All India Institute of Medical Sciences, we had people trained not only from various clinical disciplines, but we had a statistician, we had a health economist, and we had a social scientist trained. So clinical epidemiology shifts clinical thinking from either certitude, absolute certainty that sometimes we clinicians have, that this has to be it, or guesswork, oh, this could be it, to estimation of probabilities. David Sackett said that absolute certainty is only the privilege of the divinity and like-minded clinicians. But what we really have to think of is in terms of probabilities. The evolution of clinical epidemiology, therefore, moved from clinical encounters and initial off-the-cuff impressions to carefully gathered and interpreted evidence. So from reports on individual patients, that is case reports, to case series, to observational studies, like case control and cohort studies, clinical trials, then meta-analysis of multiple studies. But now we are moving into the area of complexity science. And all of these is part of the evolution of clinical epidemiology. When we are interpreting published research, we have to recognize there are several pitfalls. And as a resident in medicine and as a senior resident in cardiology, and then as a young cardiologist, I saw several of these studies being published. And they also show how even reputed journals can publish very flawed studies if you do not really apply the rigorous methodological principles. J.R.A. Mitchell was a great writer and analyst of various published articles, including trials, and widely feared because of his incisive writing. In the British Medical Journal, he himself reported a series of studies in the BMJ and elsewhere. He said coronary care units are not needed because they offer no advantage over home care. And even if some people have to be admitted in the hospital, they offer no advantage over general medical units. Now, his study of comparing coronary care unit with general medical units consisted of such a small sample size that it was unable to detect even a 25% reduction in mortality. It was powered only to detect 40% reduction in mortality. Now, that obviously was a totally flawed study, but later on several studies did show the benefits of coronary care units, and of course you had thrombolytic therapy, many other interventions coming in as a result, saving valuable lives. But of course, now thrombolytic therapy also can be administered in community settings, but that's in a different way. Then we had the Cambridge Heart Antioxidant study. This particular trial, published in the Lancet in the late 80s, said that vitamin E had a very important benefit for the heart in patients with acute myocardial infarction. It did not save lives in terms of deaths prevented, but it reduced the number of non-fatal myocardial infarction. Now, this was a study done in 2,000 patients, and it went to town saying, oh, it has a great benefit for non-fatal MI. But actually, the fatalities, the fatal MIs were more in the treatment group. They just stopped short of statistical significance. Now, if I am dying of an MI, I am not available to have a non-fatal MI, to be counted as a non-fatal MI. So that was the distortion there. And when later on a study by the British Heart Foundation, subsequently, and the National Health Service did a study with 20,000 patients, they found that there was absolutely no benefit of vitamin E or other antioxidants on either fatal or non-fatal other vascular events or even on cancer. So the question is, if we do not do an adequate study with the right kind of methodology, then we are likely to jump to wrong conclusions and mislead clinical practice. And of course, Richard Peto in the ISIS trial of streptokinase and aspirin said that using thrombolytic therapy like streptokinase and aspirin was very beneficial for reducing mortality in acute MI, except in two zodiac groups, Libra and Gemini. And people wondered why it was. This was a mischievous inclusion in the paper because Peto, as a statistician, wanted to show the fallacy of subgroup analysis. Now, if you say Libra and Gemini, everybody will say, oh, there's something funny going on here. But suppose we had said, in women with inferior MI, it does not have a benefit, people would have believed it. So doing subgroup analysis is always a problematic area because you're doing multiple significance testing and you will end up with incorrect conclusions. And then, of course, there have been studies from Norway saying that coffee increases the risk of heart attacks, but without adjusting for smoking rates. People who drink coffee in those days used to also smoke more, so that used to be the challenge. So these are the kind of things that, despite making it into prestigious journals, have clear methodological flaws, and that's why clinical epidemiology becomes very important. And tripping on data, floating numerator, quoting that, okay, we had 10 patients, we saw 10 patients with autism who received measles vaccine. and maybe measles vaccine causes autism. This was a paper published in Lancet, which created havoc all over the world, led to anti-measles vaccination campaigns, till people said, you're only giving the numerator. What about the thousands and thousands of people who received the measles vaccination? So what is the proportion of people who developed autism, if at all? So having a floating numerator is a problem. Multiple significance testing is a problem. Not following intention to treat analysis is a problem, because in a clinical trial, randomization is done in order to produce balance both between the known confounders and the unknown confounders. And the moment you deviate from an intention to treat principle, you are upsetting that randomization, the balance created by randomization. Deviating from a priori hypothesis, not following your primary hypothesis or previously stated hypothesis, and then doing data dredging to come up with some other finding, because you have to justify your study somehow. So those are the kind of problems that have been repeatedly there. And not differentiating between hypothesis generating analysis and from hypothesis testing. Most of the secondary hypotheses are hypothesis generating, not hypothesis testing. So these are the problems that we need to be aware of, because even if we are not researchers ourselves, we are consumers of research, and we have to really understand whether the kind of changes in clinical practice that we are likely to adopt are based on sound science or flawed science. But then the whole idea of objectivity was integral to the spirit of science right from the beginning. Karl Popper, the famous philosopher of science, said, the method of science is to assemble available facts, to make a bold conjecture on the basis of those, and then gather evidence in a systematic manner to disprove that hypothesis. The whole idea is not to go ahead and try and, with great enthusiasm, try and prove a hypothesis. The idea is to state the null hypothesis and try and prove the null hypothesis, and only if you cannot prove the null hypothesis, with some reluctance, accept that the alternate hypothesis may be true. So essentially, the scientist is being asked to be objective. But from hypothesis testing, we also recognize that that itself is not enough. There we are really looking at statistical significance, which is assessing the play of chance. Okay? The observed result, to what extent could be explained only by chance? And then we say, okay, less than 5%, less than 10%, and we say there's the p-value. But then we also look at the alpha error or type 1 error, which is the false positive. If we actually play with too many of the variables and have a table with multiple p-values, we are likely to have a false positive, that's an alpha error. At the same time, if you keep increasing your sample size to huge numbers, even a trivial difference can appear to be significant and get a p-value. The beta error is when you miss true association despite it being present because you're heavily underpowered. Like, for example, the coronary care unit study that I mentioned. There is also a type 3 error, which President of the American Statistical Association once said in his address, that is, using precisely the right methodology to answer the wrong question. So to frame the question is also important of what significance it might be of. And therefore, the clinical and public health significance is going to be absolutely important, and we need to assess the impact. There, we have to really look at what beyond the statistical significance into the clinical and public health significance by asking the question, even if true, how much would it matter? So the effect size becomes important. The confidence interval becomes important. How narrow or wide the confidence interval or uncertainty band is. Now, understanding risk and causality very clearly it was stated by Louis Fisher, one of the big men in statistical analysis, that association is not causation. Just because you have found an association, it's not causation. You have to have criteria for inferring causality. And for infectious diseases, we then developed Cox postulates. And for non-communicable diseases, the Hills criteria, Austin-Bradford-Hills criteria. But we also recognize that this causality is not always a dichotomous affair. Though we are conveniently say hypertensive, non-hypertensive, normal cholesterol, high cholesterol, obesity, non-obesity, we recognize now that there is a continuum of relationship of an ascending gradient of risk, whether it is blood pressure, body mass index, cholesterol, or even viral load for that matter. But we also recognize there are other relationships, like a tipping point in climate, where there can be a sudden increase in risk. Then there are interactive risks, like in cardiovascular diseases. Multiple risk factors can collectively create an enhanced risk. Then in climate science, there are different types of risk relationships: linear, cyclic, escalating, and relational. And in weather and COVID, we have developed ensemble models of risk prediction. So the moral is, it may be convenient to think in terms of normal and abnormal, but attempts to divide anything into 2 digits must be regarded with suspicion. And therefore, we ought to be really looking at different types of relationship, particularly a continuous relationship. Now, for most clinicians, diagnostic tests are absolutely important. And that's where clinical epidemiology has evolved over the years. We started off by understanding sensitivity and specificity, and most papers on diagnostic tests still stick to that. But they have their limitations. But we then moved on to positive predictive value, negative predictive value, receiver operating curve, likelihood ratios, it should be receiver operating curve, likelihood ratios, pre-test and post-test probabilities, and decision failure rate. One of the things is, okay, if you apply a particular diagnostic test, what are the decisions you are likely to come to? And if you do not apply that diagnostic test, will you come to the same decisions or not come to the same decisions? Suppose, let us say you do a non-invasive diagnostic test for a valvular heart disease and then do a cardiac catheterization test. What is the decision failure rate by only applying echocardiography? So that is the kind of question that you want to be asking sometimes. Now, one of the things that was very important is Sir Thomas Bayes talked about conditional probability. Now, what we have always interpreted in absolute terms as the test result as a positive or negative is not entirely true. We have to think in terms of probabilities, and that probability is dependent not only on the test result, but in the context in which it was applied, to what type of person it was applied to. And then only the final result will come in. Just to give you an example, if a 60-year-old male who is a smoker, diabetic, comes in and has a positive stress test, 2 millimeter ST segment depression horizontal, everybody would agree there's a high probability of that person having coronary heart disease with blockages. If a 25-year-old woman with anemia and hypothyroidism comes in and has the same 2 millimeter ST segment depression, would we judge only by the test result? Clearly not, because we would say it's a false positive. Therefore, the context matters, and that's what Bayes said. Do not only go by what you see in the result. You are allowed to look at the prior probability, and then look at the test result, and then calculate the posterior probability. And Nate Silver is a remarkable person. He started off with baseball games in the United States, then went on to election forecasting. He was one of the best forecasters of baseball scores A film was also made on him. But he also started forecasting election results, and he had remarkable capability of predicting even state by state what would be the result in a presidential election. And he has written a beautiful book, The Signal and the Noise. In that he says, information becomes knowledge only when it's placed in context. Without it, we have no way to differentiate the signal from the noise, and our search for the truth might be swamped by false positives. He is a strong votary of Bayesian analytics. Now, what has happened in terms of Bayesian analytics is that Louis Fisher, who I referred to in the beginning, who said correlation is not causation, and he was considered the real towering figure of statistics, Bayes preceded him, but Fisher hated Bayes and did not allow statistics to really take into account Bayesian analytics till very, very late. And Fisher propagated what are called frequentist statistics, what we conventionally grew up on, even till recently, the classical statistics, but without looking at these probabilities, conditional probabilities. But over the last 30 years, the whole world has begun to realize that Bayesian analytics are absolutely important. We have to think in terms of conditional probabilities. When I went to McMaster University in 87, 88, I was not taught Bayesian analytics. But now you cannot find any decent university not teaching Bayesian analytics. So in the evolution of clinical epidemiology, even at AIIMS, it becomes important. Okay, not going into too many details, we know that by the 2x2 table, which is the real mool mantra of epidemiology, we have true positives, false negative, and true negative based on test or exposure. And we know that we talk about sensitivity and specificity, and in order to look at the balance between sensitivity and specificity to try and balance, we try and look at the receiver operating characteristic curve and look at the area under the curve, because we know that when sensitivity increases, specificity decreases, and when specificity increases, sensitivity decreases. So we want to capture the point where we are getting the best area under the curve. And we also know that sensitivity and specificity are useful for evaluating the performance of a diagnostic test in a mixed population, for assessing the performance of the test, not of the patient, remember. But they don't tell us about the likelihood of the individual having the disease. If I am sitting in the cardiac clinic, or Dr. Ambuj Roy is sitting in the cardiac clinic, and the patient comes and sits in front, and the sensitivity and specificity of the treadmill test doesn't tell me what the patient is having. It only tells us how the test performs, right? So we come to positive predictive values and negative predictive values. We try and say, okay, for this particular person, if the test is positive, what probability is there of the person having the disease? Or if the test is negative, what probability is it of the person not having the disease? But, wonderful, but the predictive values are so vulnerable to prevalence of the condition in the population. If you look at this table, sensitivity is 0.53 and specificity is 0.92 in both the tables, both the charts. But the prevalence in this case is 0.5 or 50%. The prevalence in this case is 10%. For the same sensitivity and specificity, you get very different positive predictive values, 0.87 in one case and 0.42 in the other case. So, unless you know what the prevalence in the population is, you cannot even judge predictive values. So that is where context comes in. That is where Bayesian principles come in. So you have to know the context. And for this, we have a different statistic. It's called the likelihood ratio of a positive test result. Now, these are much more person-specific or patient-specific, but not prevalence susceptible. They are not affected by the prevalence. So this is like a gambling odds. This is the ratio of the proportion of with a positive test result in those with disease to the proportion with a positive test result in those without disease. That is the odds that a positive test result would be expected in a patient with disease as opposed to the one without. These are odds. Similarly, you have the likelihood ratio of a negative test result, which are odds that a negative test result would be expected in a patient with disease as opposed to the one without. So now we have these excellent ways in which we can actually interpret a test for the person sitting in front of us, but without necessarily being vulnerable to the context. So here we have the prior probability and the likelihood ratios, and together they yield the posterior probability. That's what Bayes says. And now here is an algorithm or a nomogram in which you can say, okay, this is where is the pretest probability, this is the likelihood ratio generated by the test, and therefore you can draw any line from there and say what is the probability of this person having a positive test result, having disease. So these are the kind of things that clinical epidemiology has developed in order to make diagnostic tests much more efficient in clinical practice. Now, remember, the post-test probability derived from one study becomes the pre-test probability for another study. And then you can keep on refining your instruments. As Piet Hein, a mathematician from Denmark, writes on The Road to Wisdom, err and err again, but less and less and less. Therefore, as we move along, we reduce the margin of error as we keep on going through this repeated probability assessment. Now, there are also measures of agreement. If there are 5 observers doing a study, do those observers actually agree with each other? Or is there a likelihood of disagreement? Or even if I repeat the measurements in different people, do I agree with myself each time? I may not. There are intra-observer and inter-observer differences. And for that, we have now for categorical type of variables, the kappa test, which are different types of kappa tests, weighted kappa and so on. And for continuous variables, we have the intra-class coefficient and the Bland-Altman method. The point is not that there are various tests. The point is everywhere by chance alone or by inherent random error alone, people may agree or disagree. You have to really estimate what is the level of agreement which could arise by chance alone before you assess what is the level of true agreement. And therefore, these tests become very important. Suppose you are doing a study with 3 senior residents doing the same types of assessment. You'll have to really see what is the level of inter-observer agreement among them. Otherwise, the paper will not get published now because intra and inter-observer agreement with kappa or intra-class correlation coefficients will have to be part of the reporting of statistics. Of course, there are different types of study designs: ecological studies, surveys, case-controlled studies, cohort studies, and clinical trials. And there are different levels of assessment of the risk and benefit of interventions. What we call relative risk, absolute risk, population attributable risk, number needed to treat. One of the biggest flaws that we make when interpreting clinical trials is the authors frequently report relative risk. Relative risk is only telling you what is the reduction in risk between the so-called effective intervention and the control group, but doesn't tell you actually what is the amount of benefit conferred on the entire patient population there. if your absolute risk is very minimal to start with, even a relative risk of 50% doesn't make difference. If your actual mortality rate is 2% and your relative risk reduction is 50%, great, but you only reduced it to 1%. On the other hand, if your mortality rate is 12%, yes, 50% reduction would come to 6%. Or if it's 20%, it will come to 10%. So the absolute risk reduction becomes very important. And of course, at the population level, you look at population attributable risk, but you also look at what's called number needed to treat. Then you look at the incremental benefit of the intervention, and then the incremental cost effectiveness of the intervention. Now, all of these are part and parcel of clinical epidemiology investigational methods. Clinical trials are now evolving. Apart from the so-called standard clinical trials, we are seeing factorial trials in which, like for example, in the ISIS-2 trial, they looked at how streptokinase and aspirin alone and combined compared to placebo can actually confer benefit. 23% benefit with aspirin, 25% benefit with streptokinase, combined benefit 42% reduction in mortality. N of 1 trial. We generally are now asking for large, simple, randomized controlled trials so that they can have adequate sample size and a good estimate of benefit. But then sometimes you can do a trial in a single person in a chronic stable condition like hypertrophic cardiomyopathy, for example, or rheumatoid arthritis, for example. You can randomize treatment methods in the same person and get both subjective and objective measures of improvement or otherwise. So if you're testing, for example, in Ayush, that may be one method of testing, of doing an N of 1 trial. So again, we have to look at the different types of trial methodology, but multicentric trials have become common now because they can give a large sample size in a shorter time, and they also bring in diversity of population. Unless we bring in the diversity of gender, ethnicity, most trials will not be accepted now. Previously, trials used to be done only in males, and the results used to be applied to women, whereas there were so many differences. Now, therefore, most trials insist on racial and gender diversity. Then there are crossover trials and what are called step wedge trials. I'm only listing them to show that clinical epidemiology is evolving. It is repeatedly upgrading its own methodologies and thereby meeting the challenges of answering complex questions in complex times. For example, during COVID period, we heard of the platform trials, whether done in UK or globally by WHO solidarity trials. Now, a platform trial is a type of prospective, disease-focused, adaptive, randomized clinical trial that compares multiple simultaneous and possibly differently timed interventions against a single constant control group. You have a single control group, but you're trying different treatments against the same control group at different times, and they're able to find out what works best. As a disease-focused trial design, while compared to the conventional intervention-focused trial, platform trials attempt to answer the question, which therapy will best treat this disease? So you're able to throw multiple treatments into the box and then say, okay, I'll come up with a quick answer using the same control group. So there are different trial designs that have evolved to answer questions at a time of like COVID. So the Bayesian application of clinical trials, again, there are so many of these Bayesian applications in clinical trials, I'll not get into them. But just look at the bottom line. This is from the US Health Services and the FDA, the Food and Drug Administration. This is for the medical devices. So with prior information, you can do smaller size or shorter duration trials. Without prior information, these are the type of trials that can be done. So again, Bayesian statistics have become very important even for medical device evaluation. But then we are also dealing with a huge amount of data flow. As this particular poem by Edna St. Vincent Millay says, upon this gifted age in its dark hour, rains from the sky a meteoric shower of facts. They lie unquestioned, uncombined. Wisdom enough to leach us of our ill is daily spun, but there exists no loom to weave it into a fabric. So what do we do with all these diverse sets of data? We get artificial intelligence. But artificial intelligence also depends on Bayesian networks. Julia Pearl says, probabilistic reasoning in intelligent systems uses Bayes' theorem of conditional probabilities to go back and forth between cause and effect. As the data scientist from MIT, Josh Tannenbaum says, if you can describe your knowledge for all the different things that you're interested in, then the mathematics of Bayesian inference tells you how to observe the effects and work backwards to the probability of different causes. So again, in artificial intelligence, you have to learn about Bayesian networks. Epidemiology is gaining strength. It has excelled in independent attribution of variables to cause and effect while paying attention to interactions. In the era of microbiome and epigenomics, it has transitioned to adopt integrative epidemiology as an investigational platform and life course epidemiology as a field. The interactions between the metagenome of the human genes as well as the mini genes of the microbiome that lies in us, that's the metagenome, and the superphenotype, that is not only the physics but the environmental determinants, are being avidly studied. And therefore now you're getting social epigenomics and environmental epigenomics as fields. These again have to become part and parcel of clinical epidemiology's study. However, there is a challenge. Epidemiology has not yet become adept at studying multiple adaptive systems. It has not helped to identify critical points at which phase transition occurs. Reality is complex and first obeys non-linear and multi-causal relationships. All the statistics that we have been taught mostly are for studying linear relationships. But unfortunately, many of these things are not totally linear. COVID has taught us how complex the world is, whether it's multiple variants or the interaction with people accepting masks, not accepting masks. The whole field is complex. I'm not going to really go into this. But what are complex systems? They are co-evolving multi-layer networks. Elements interacting in a system result in a behavior or an outcome that's more than the sum of its parts. Now, the key premises of complexity thinking are that a complex system has a large number of dynamically interacting elements, non-linear interactions, wide diversity of elements, emergence of new variables, feedback, unexpected variability, path dependence, self-organization, and resilience. The reason I'm mentioning this is not to really create complexity in the presentation, but to say that complexity science has become very, very important now, and we will have to study it, whether in the clinical context or in the health system context. Complexity should not be confused with chaos. Complexity has simple interactions between large numbers of subunits, whereas chaos has very few interacting units, but very intricate dynamics. But we also need to proceed to implementation research. Clinical epidemiology does not stop with the hospital. It has to go to health systems. How are various interventions actually being incorporated into health systems, whether in the form of guidelines or in the form of health programs? How are they functioning? All of this becomes important because that kind of research too must be driven by proper scientific methodology, which clinical epidemiology can provide. And to influence policy, enlightened policy needs scientific credibility, aided by biomedical, epidemiological, and clinical research. It requires financial feasibility from health economics research. operational stability from health systems or implementation research, and political viability from social science research. So training of epidemiologists will require crafting of competencies in multiple areas if they have to become change makers. Complexity matters, that is big data from multiple sources. Context matters, that is Bayesian analytics and models. Comprehension matters, mixed methods research, that means both quantitative and qualitative research. Caution matters, estimating uncertainty. We cannot be absolutely certain about everything. We must recognize there is uncertainty. That's why we think in terms of probabilities. And communication matters, which has to be clear, coherent, and consensus building about what we are recommending based on our research and our estimation of those probabilities. So as Louis Pasteur said, and that he said to his research fellows, but that applies to anybody who is a clinical epidemiologist or an aspirant clinical epidemiologist. Keep your enthusiasm, but let strict verification be its constant companion. Don't take anything for granted. Simone Weil said, attention is the rarest and purest form of generosity. Thank you very much for your gracious invitation and for your generous attention. Thank you.
Thank you, sir. It's my great fortune to deliver this vote of thanks because sir has been my guru in multiple ways. So thank you to the Clinical Epidemiological Unit for choosing Professor Reddy for this lecture. I don't think there could be anybody more appropriate for this lecture because he's seen the whole gamut of the changes in epidemiology that has come out in the previous few decades, and that was very well brought out in the nuances that he explained in his lecture. I also thank the leadership for confirming and getting him to be here. Unfortunately, director could not come because of some last-minute commitment. I thank the audience for being here, and I think this is also available online and will be available on YouTube channel of AIIMS for people who might have missed, and they could always go back and see this. And of course, last but not least of all, thank sir for delivering this lecture, taking time out from his ever busy schedule where he's wearing multiple hats all the time. And I'm just taking from the Peter Heen's Road of Wisdom, which you said, sir, from you we always learn and learn more and more and more. So thank you so much for being here. I personally gained from you, as some sir said, an intellect, academician, a thinker in public health, but he's also a phenomenal human being. And I've learned not only clinical cardiology, but common courtesies to patient, to colleagues from you, not only learned public health, but private congenialities to everybody from you. So thank you so much, sir, for being here. And it's my pleasure that you were here. Thanks from the AIIMS fraternity once again to you. Thank you.